Also, Kathy, just FYI, yesterday, Monday, when we did our practice run, both Bram and Deborah wanted question 3. I just realized that.
Oh, I thought that I don't have them queued up, but I thought that by last question, Deborah meant the one that wasn't called for.
I hope so. Then it's question 2.
Yeah, that's what I had understood. But
okay, that's good, because I was like, well, that the third one sounds really Bram from his expertise, and it fits nicely. But okay, that's good.
Yeah.
Because when she said last question, I was like, I'm not going to argue with you, but do you mean the third question? Because then you are 2 of you wanting to answer the same one.
Yeah, I thought she meant the one that wasn't called for. Also, I thanks Naomi for starting the recording. Are we able to trim it the first 10 minutes off, or should we stop and start the recording when we are ready to begin?
Let it just record. When sharing, I'll make sure I crop off the beginning.
Awesome. Thank you.
All right, I'm setting up the chat and making sure that I have a pen in case I have to give myself a note to go back and see how many.
And thanks, Naomi, for making time for us when you're dealing with the conference coming up. Best of luck with everything.
Hello, hello.
Hi.
Yes, Sibley, Naomi, Kate. Good morning.
Good morning.
Oh, Katie, do you see that Mohammed needs access to the webinar? Oh, you got it. Yeah.
Oh, I sent it to him.
Thank you. I just saw that.
Hello, good morning, everyone.
Good morning.
Good morning.
Anita.
I was trying to create a side Teams channel.
I wonder if we
Can
will
we do
have the
that?
headspace to have a side chat. I think it might be better just to
use Zoom?
Yeah,
Okay.
like you can send direct messages in Zoom.
Yeah, okay. We can
Yes, you
select
can.
how to send.
Yeah. You look down and say everyone, or you can see someone specific.
Yes. Okay.
Hey folks, good to see you all. Hopefully you can all see and hear me. Good
Yeah.
morning.
Good morning.
Good morning, Bram.
Morning.
Looks good. Now we just need Deborah.
I think we're good. Yeah.
And maybe for bandwidth, we might need to turn our videos off unless we are the speaker, right?
I don't know that you need to necessarily turn your video off. You might want to mute.
Yeah, definitely we have to mute, but yeah, let's see. Because people are joining from different places. I don't know if it will affect the bandwidth.
Oh, I don't know. I don't think so. Naomi? Does it make a difference?
I think she's on mute.
Just quick question, Kathy. When do you want me to tell people, or because you told me to tell people that they can ask questions? Maybe you want to say that right at the beginning, like whoever's, I mean, you are doing the introduction, correct? The first one?
Great. So I'll say it during my part. I'll also put it in the chat at some point while the speakers are going, just as a reminder that people can put their questions in the chat.
I can
And I
type in
think
the
when-
chat if you want, but if you
Okay.
want to just tell them, well, because then I don't want to interrupt anybody. And then I
Yeah.
can just, tell.
For you, I meant we do have a question slide after all of the case studies are done. So that's your opportunity to like unmute and kick off the Q&A. So you can say whatever you want, but I was also just hoping that you could also mention like, we're going to stop sharing the screen so that we can see the panelists so that I can stop sharing
Yes.
at that moment. Yeah.
I will do. I'm happy to do that.
Great. Wonder where Deborah is. I had closed out of my email so I don't get pop-up notifications. Have we heard anything from Deborah? I don't see anything yet.
Hopefully everything's okay on her end. Plan B, if she doesn't show up, Yordi talks about the UA project in India from our Pathfinder days. Yordi.
There we go.
I have that memory, goodness, yeah. But we have 3 excellent questions, right, Sibli?
We do. We have
can
excellent
dig deep
question.
into
I can ask you guys all the questions. Oh, there you go. Oh no.
Yeah.
No.
All right. Looks like we have Deborah with us now as well, and some participants joining. Perhaps we can go ahead and get started since we have a lot to cover today. Wonderful. So wonderful. Let's get started. First, I'd like to start off by thanking everyone for joining us today on behalf of the Core Group Monitoring and Evaluation Working Group. The co-chairs of the working group are me. I'm Katie Gurantz, a Senior Monitoring and Evaluation Specialist at Chemonics International, Sybil Christensen, Chief Operations Officer of One Heart Worldwide, and Jordanis Mel Lead at Apt Associates. We're so glad that you've joined us for this webinar, From Theory to Practice, Monitoring and Evaluation Approaches to Strengthen and Evaluate HCD Projects. So we have 3 expert panelists today, including Juanita Rodriguez, the studio lead at ThinkPlace. Juanita is an avid maker, invested in tackling the most complex societal problems by designing transformative solutions from an empathic and optimistic perspective. She has worked in multiple countries across Africa and Latin America to improve the efficiency and impact of behavior change interventions in the areas of nutrition, sexual and reproductive health, poverty alleviation, economic inequality, and financial inclusion using strategic design approaches. She currently leads the human-centered design practice at the USAID-funded Breakthrough Action Program. Juanita holds 2 bachelor's degrees in business administration and design and a postgraduate degree in social innovation management. Thanks, Juanita, for joining us today. Next, we have Dr. Mohammed Ibrahim Brooks, or Brown Brooks, who is Mel Lead and Senior Manager at Pathfinder International. He is a public health professional with over 15 years of experience managing, implementing, and evaluating health and development projects in low and middle income countries. Brown works as a senior MEL advisor at Pathfinder International, designing performance monitoring systems, implementing operations and applied research studies, and disseminating evidence-based results in program learning within the global health community. He was also the mill lead for several HCD projects at Pathfinder, including the BMGF-funded Beyond Bias project. Bram has a master and doctorate in public health from Boston University School of Public Health. And we also have Deborah Freitas Lopez, a senior director and lead at University Research Co., or URC. Deborah has more than 20 years of experience leading health and non-health programs, particularly in Africa, Latin America, the Caribbean, and Asia. Her scope of expertise includes social and behavior change, gender equity and social inclusion, maternal, newborn, and child health, family planning and sexual and reproductive health, and infectious diseases, particularly malaria, HIV/AIDS, and tuberculosis. Currently, she serves as the Senior Director and lead of the URC Global, LAC, and West Africa Regional Programs. She's also Chair for the Global Alliance for SBC, a member of the FP High Impact Practices Technical Expert Group, SBC for FP, and a steering committee member of the SBC Working Group for RBM Partnership to End Malaria. She holds an MS in Health Evaluation Sciences Epidemiology from the University of Virginia. So thanks to all of our expert panelists for joining us today. And for our agenda today, we're going to start with an introduction on human-centered design so we have some common understanding going into this rich discussion. Then we'll dive into case studies from each of our panelists where they'll walk us through a real application of MEL for HCD, including the methodology, results, and the lessons they have learned and the recommendations that they may have for us. We'll then have a Q&A session where you'll have an opportunity to ask your questions to the panelists. So throughout the webinar today, please type your questions into the chat and Sybil will help us moderate those questions and present them to the panelists. So with that, I'm going to hand over to Juanita to kick us off with an introduction. Thanks, Juanita.
Thanks, Kathy, and good morning and good afternoon, everybody. Really happy to be here. And as Kathy was mentioning, I am going to be introducing you very quickly to human-centered design. I am aware that some of you might already have some experience with it, but I have the incredibly challenging task of introducing it in just 7 minutes. So I'm just going to be setting up a timer over here just for me to be mindful about time. And Kathy, if you can hit on the next slide, please. The way in which I frame this introduction is basically using Simon Sinek's golden circle. So 3 key points: why we use human-centered design, how we use it, and what is human-centered design. And intending to make this as engaging as possible, I also want to be able to get your inputs on helping me answering these questions. So we're going to be using our chat tool over here in Zoom. And to be able to move to the first question, why we use human-centered design. So I want you all to think about one word that helps us summarizing or understanding. Sorry, go on mute.
Could everyone please mute themselves? And Naomi, we may need help with muting folks as well.
Okay, I was muted too. Okay, so going back to the instructions, so we're going to be answering question by question, and I really want to get your inputs on these. So first task for you all, think about a word that helps us summarizing why we use human-centered design. Again, there are no right or wrong answers over here, but think about a word. Okay, type it on the chat. Don't hit send yet. I'm going to count 3, 2, 1. And when I say send, you're all going to press send or enter on your keyboards. All right. Think about a word. Don't overthink it. 3, 2, 1, go. Awesome. Fantastic. Okay, we got some interesting input over here: collaborative, navigation, empathy, depth, humans, sustainability, understand, empathy, equity, inclusive, impact, insights, responsive, connection, useful. Fantastic. Thank you all so much. Next slide, Kathy, please. Next slide. All right, 6 key points about why we use human-centered design. First of all, it works in many contexts. So it can be used from either creating a product from a single individual to solving complex problems as industry or policy level problems. The common denominator over here is, of course, humans. So they are the heart of the problem. So that's why human-centered design can be used in many problems. Second point, it's flexible. It's also scalable. Third point, it works in complex problems. One of the key points of human-centered design is that we focus on solving design challenges. These are often complex in nature, which means that there are multiple variables that are interrelated and interconnected, and this makes a system really complex. So we cannot explore or try to solve the problem just thinking that there is one single voice that holds a solution for it. So that's why we like to involve many different perspectives when we apply human-centered design. Fourth point about why we use human-centered design. We empower users and the users of the system, the users of a product, the users of a service and a new experience. Human-centered design is inherently user-centered. And because of that, we like to empower our users ever since the beginning of the process, when we start doing research, when we start empathizing with the problems, until we provide a solution for them. Fifth point about this, it produces outcomes that are highly usable and tailored to the target audience. This is very linked to the point that I have mentioned before about empowering our users and also putting our users in the heart of the problem. My sixth key point about the why we use human-centered design, and this is from my perspective the most important one, is that it de-risks projects through an iterative approach to concept development. The purpose of doing research, the purpose of doing prototyping and testing with human-centered design is to make sure that every single solution that we design or every single iteration that we design based on human-centered design is going to be likely to be used by our end user. So this, from our perspective, or what we try to do is to increase the probability of that engagement with the solution by involving the user and placing them in the center of the whole process. Hope this is not too fast. It's a bunch of information, I know, but I told you I had an incredibly challenging task. Next slide, Kathy, please. How? Now, let's go back to our chat. Now, I don't want you to think about a word, but I want you to use an emoji, okay? Go to the emoji icon over there and think about, don't overthink it, of course, but grab an emoji that explains how we use human-centered design. 3, 2, 1, go for it. Great, Kathy, some hands. Thumbs up, Alison, smiley faces, some ears, eyes, the world, happy faces, geeky faces, people, amazing, go ahead. Fantastic. All right, let's move on. Kathy, next slide. I like that recycle and rainbow one. Next slide, please. Again, fantastic. 6 key points over here about how to do human-centered design. First of all, we like to have a shared intent. As I mentioned before, we are not assuming that there's one single user that holds the solution for a complex problem. Because of this, we like to embed 4 key voices in our human-centered design processes: the voices of the user, the voices of experts, the voices of designers, of course, and all of these voices inherently create a collaborative process, and that's how we do human-centered design. We couldn't do human-centered design without collaboration. Third point, empathy. That is the key thing about human-centered design. There is no a possibility in which we can do human-centered design without empathizing, without understanding human and user needs. Third point, we design the whole change. And we, again, like to think about design challenges in terms of systems. So we understand that there are many interrelations, many actors, many stakeholders that are integral to a design challenge. Fourth point, very related to the shared intent and collaboration. It's a team approach. Fifth point, we do a bunch of user research. We like to empathize with users by immersing ourselves in their context to be able to understand what their realities are about. Final point about how to do human-centered design is an iterative process in which we like to touch on 3 key things that I'll expand later on when I share with you my case study about the DRC. We like to explore the circles of viability, desirability, and possibility, and that is when we hit the sweet spot of human-centered design. I'll talk more about this when I share with you the case study. Last thing, next slide, please. What is human-centered design? Last time that I'll ask for your input over here on the chat. Again, think about a word that helps us understanding what human-centered design is about. Think for 5 seconds. Write your word, type your word in the chat. 3, 2, 1, hit send. Yeah, fantastic. Amazing. I wonder how can we collect all these words later on, and then we can share those with you at some point. People, change, collaboration, holistic, inclusiveness, empathy, bridge. Awesome. All wonderful words. Fantastic. And all wonderful solutions. Again, next slide, please. Final slide about the introduction of what human-centered design is about. Next slide, please.
Sorry, I think my slides are lagging ever so slightly.
There you go. Perfect. Okay, so over here are just 3 examples of what human-centered design is about. Again, it's a methodology that can be applied to design products, services, spaces, websites, policies. And the key principles of what human-centered design is about is that it's not an independent process. We like to collaborate between designers, experts in the nature of the problem that we're solving, and end users, those users who are very closely to the problem that we're going to be solving. We move away from assumptions. So that second example in the second row in the column on the left, we move away from assumptions and we move into that immersion phase in which we understand and immerse ourselves with our user needs. Final image over there is that it's also a very iterative process. So we don't intend to produce a final perfect solution on the first try, but we like to give our user the opportunity to interact and to give us feedback about that final product, that final service that we have designed together with them. Last slide about this introduction of human-centered design. And it is just a provocation for all of us. And next slide. Okay, a bit of a teaser. The next slide is a quick provocation about what can be explored beyond human-centered design as of now. So I want to make sure that everybody is listening right now, or is my internet connection okay?
Yes.
Yeah, okay. I'm not seeing the final slide. Should I share my screen?
Yeah, go ahead and share
Yeah.
your screen while we wait for Katie.
Awesome. Let me look for the slides now. Here it is. Okay, 1 second. There you go. Can you all see my screen now?
Yes,
Yeah.
Magda.
Awesome. So last slide about this introduction of human-centered design. As I said before, this is just a bit of a, I'm planting a seed. I'm making a bit of a provocation over here. There has been a lot of exploration about human-centered design. It has been around for over 30 years now. And one of the concerns right now is that we have placed the human far too much in the center without actually connecting the impacts of the solutions and the interventions that we're designing with our planet. So how can we also measure the success of applying planet-centered design? What are those KPIs that will help us communicate the process in not only doing human-centered design, but human planet-centered design? How can we make the voices of non-human actors also be heard? And how can we also support each other collectively to develop more approaches related to human planet-centered design practices? And with that, I will move forward with the case study that I wanted to share with you. So this is a project that we did in collaboration with Breakthrough Action and ThinkPlace. And it was a project that we did in the DRC. So we used human-centered design to encourage essential family practices and healthcare seeking in the DRC. We focused on 2 key provinces, so Kasai Oriental and Okatanga. And this was a project that, if I am not wrong, was done in 2018 and 2019, before the pandemic. This is a brief example and image in which I just wanted to share with you very quickly the audiences that we engaged throughout the process. And back to my point about making sure that we involve sufficient voices in complex problems, we are intended to engage these users throughout the process. So not only through research, but also through prototyping, which is the moment in the human-centered design process where we co-design our solutions. We like to involve as many users that are related with the complex system that we are approaching. So in this case, as I said before, we were touching on 2 key challenges. The first one was to encourage healthcare seeking. And the second one was also to encourage parents to follow essential household health practices. So we involved pregnant women, we involved mothers of children under 5. We also involved their partners and key influencers that you can see on the gray circle over here. Members of the Ministry of Health, community leaders, healthcare workers, and others that you can see over here. Within this project, we use the human-centered design approach, but we also brought the SVC flowchart, which is a framework that we co-created with other partners in the Breakthrough Action Consortium. And it's a process that is a 3-phase process. So the first one is define, in which we do or that process of empathizing with the user's reality. So we deepen that understanding of the context, we deepen that understanding of the user and day-to-day lives. Second phase is the design and test phase. So this is the moment where we also bring all these voices that I shared with you in the previous slide and come together to ideation workshops. And over here, we collaboratively, again, co-create or imagine solutions for those problems that we identified in phase 1, which is define. After this, we're still in phase 1. We start refining some of these ideas and begin to prototype, build some of these concepts really rapidly, sometimes really dirty. But the main purpose of doing this approach is to test things and to iterate really fast. Over here, the key point, and this is kind of the key point of the conversation about how we measured this in the DRC, was through the 3-circle approach that I mentioned to you in the introduction of human-centered design. We focused on understanding the desirability, the feasibility, and the potential scalability of some of the solutions that were co-created with people from communities in those 2 provinces where we were working in the DRC. Once we were able to go through those 3 circles or those 3 testing sprints, we moved then on to the apply phase, which is the 3rd circle that you can see on the right. And it's also a gradual process, but in which we move on to implementation. Over here, we use most successful change stories as a way to understand how our interventions were tracking and if they were actually being able to change the key behaviors that we were addressing and targeting with this project. And my point about measurement for this case study is mostly focused on, as I was saying before, in this, second phase of this design process of what happened in the design and test phase, and that iterative process where we moved through these 3 circles. So in general terms, when human-centered design, we try to hit that sweet spot, as I mentioned earlier, that creates solutions that are desirable, that are feasible, and that are also scalable. And in this particular project, we created some qualitative indicators that could help us understanding whereas those solutions were desirable, feasible, and scalable. Our first testing sprint, which was a low fidelity sprint in which we created interventions that were sometimes very quick mockups, very fast interventions that we put together really quickly, such as events, but we mobilize people really quickly in order to be able to learn about the desirability of these potential solutions. So for that first circle of desirability, we wanted to understand if the solution was likely to lead to uptake or change from key audiences. So key things that we took or a look into were if that solution had the potential of improving current practices or precedents, if the solution was also perceived as relatively easy to understand and use, if we also observed that the user was engaging with the product, with the service, or with the experience that we were offering, and in general terms, if this solution was actually providing some value to the users that we were working with. Once we were able to understand that these solutions were desirable, meaning that they checked all these boxes of advantage, simplicity, engagement, value, etc., we moved that solution into a second phase where we refined these prototypes. And then what we wanted to know over there was how feasible that solution was to be operationalized. So we looked into 3 key indicators over there: how logistically feasible that solution was, how technically feasible it was, and then to what extent we were seeing some indicators of that behavioral validity. So was that solution actually having some indicators of potential to lead to the desired behavior change that we were aiming? Once again, once a solution take those 3 checks of logistical feasibility, technical and behavioral validity, we moved it to scalability. And over here, you can imagine that we started with more solutions that we ended up discarding some that didn't pass all these checks. And then we moved on to the 3rd circle over here about scalability, where we wanted to just make sure that the solution was easily replicable with the resources that we had for the project. And we wanted to make sure that it could also be replicated across contexts, and that we could also start to see that advocacy piece about promoting and or detracting the innovation or the service that we were creating. Finally, some of the key lessons learned that I wanted to share with you are about focusing on these 8 points that I highlighted over here. And I wanted to make sure that I conveyed the message about the importance of understanding that we are dealing most of the time with complex systems, and acknowledging that it's a complex system that won't be solved by one single human experience was for us one of the key important things that we did in this project. So understanding and acknowledging the complexity of the system, and understanding that there are indicators that have to be moved as we iterate, as we move forward in testing, is going to ensure that we can then zoom out and zoom in into the whole system perspective to understand individual needs, but also systemic needs. So I'll share these slides, of course, with everybody, but the importance of this project in particular was that we were able to touch on these 8 points over here. And because of the iterative nature of human-centered design, we had to move into the human experience. We had to zoom into the understanding of the individual and then be able to zoom out. We have to acknowledge and extrapolate the system also within the time constraints that we had. But I know that I have taken more time than I had intended to. So with this, I'm going to be closing my case study and then passing it on to Bram. And he will be sharing with us a project that was done with Beyond Bias. So Bram, off to you.
Great. Thank you so much, Juanita. And folks can see and hear me, I hope. But in any case, wonderful overview of HCD. I like the term PCD that you shared as a teaser, Juanita, and great case study from the DRC. So I'll be sharing my experience working on the M&E approach for the Beyond Bias project. Let's go to the next slide, please. All right, so the main goal of the Beyond Bias project was to design and test a novel and scalable solution aimed at addressing provider bias for youth seeking family planning services in 3 countries, Burkina Faso, Pakistan, and Tanzania. Provider bias, such as a belief that young unmarried people should not be sexually active or that young married women should prove fertility, is a driver of judgmental and poor quality sexual and reproductive care around the world, especially in low and middle income countries. The project was a collaborative partnership between Pathfinder, the prime that provided the platform to implement the Beyond Bias intervention in different country contexts, Y Labs, our partner who helped us develop a novel intervention using HCD, and the RAND Corporation, our external evaluators with expertise in behavioral economics. Together, this consortium designed, developed, tested, and implemented and evaluated the Beyond Bias intervention. Since this is a project that utilized an HCD approach, there are different phases to the project as shown on this slide. And the steps related to HCD are those shown in light green circles: the idea generation phase, rough prototyping, live prototyping, and you'll see a lot of those little circles which indicate levels of iteration within phases and between phases. So for this particular talk, I'll be sharing my M&E experience associated with live prototyping. I think this is a unique phase within an HCD project where you have the basic intervention approach and modality, but you're still tinkering with the solution set and trying to figure out the opportunity and the potential for impact. So in any case, let's learn about the basic approach of the Beyond Bias intervention in the next slide. Next slide, please. All right, the Beyond Bias solution set is based on a behavior change strategy. At the end of the day, the intervention is designed to change providers' behavior on how they treat adolescents coming in for family planning services. So the Beyond Bias intervention is comprised of 3 pillars or components, highlighted by the 3 icons that you see in the upper portion of the slide: the summit, connect, and rewards. If you visit the Beyond Bias landing page on the Pathfinder website, you can learn more about the details of the Beyond Bias project there. But for now, I'll just quickly summarize the different pillars of the intervention. So let's start with the summit, which is a story-driven one-day workshop meant to activate providers' self-awareness of their own biases and build empathy towards youth. For Connect, this involves interactive shared learning forums where small groups of providers share experiences and problem solve with their peers to apply unbiased family planning services. And finally, for rewards, this is a non-monetary performance-based initiative based on client feedback that looks at provider behaviors. When developing any M&E system, it's always important to develop some sort of theory of change or causal pathway to figure out the underlying mechanisms and help present some of the key outcomes of interest that the intervention is trying to change. So in this slide, I'm sharing with you the simple M&E framework that was developed for the summit pillar towards the bottom of that slide, such as improving emotional connectivity with youth, addressing provider fears of community backlash, providing FB services. So from the M&E perspective, when it comes to prototyping potential solutions, we want to know if key activities activities, or success ingredients, as we like to say in our project, were implemented as designed, so looking at issues of fidelity, and whether the key outcomes of interest happen. So for example, did the prototype of the summit pillar improve empathy for youth among providers? So we're trying to figure out whether it moved the dial on attitudes and beliefs among the providers themselves. So I'll provide a concrete example of how this was done in the next slide. Let's go to the next slide and see what we have to play with. So when working on any M&E system, it's always helpful to figure out some of the key questions that you're trying to answer. So in the live prototyping phase of our HCD project, we're trying to see if our solution set is changing key behaviors of interest, and to figure out what is working, and also conversely what's not working as it relates to the potential solution set. So you'll see on top of this slide the two learning questions that we are trying to answer as part of our M&E approach for the live prototyping phase of our project. And in order to answer these questions, we had a mixed methods approach comprised of provider surveys to assess changes in key attitudes and behaviors, focus group discussions with providers, in-depth interviews with implementers to better understand some of the implementation successes and challenges. And as you can see from our sample size numbers here, we have a limited number of participants, and that's mostly because we're live prototyping in a small number of health facilities. And as a result, we're not really looking to detect changes that are statistically significant and findings that are generalizable. However, we do want to look at patterns to see if the basic intervention modalities are working and whether there's an opportunity to improve the solution set before we actually implement at a bigger scale. And get ready to call in our external evaluation team to see if this intervention is effective at the end of the day. So let's take a look at some of the results from live prototyping in our next slide. All right, so for our provider survey, we're asking, in essence, a series of Likert scale questions on statements that assess the level of agreement that providers have to key attitudes and beliefs, such as, do you agree that IUDs are not appropriate for women without children, and hormonal methods are bad for youth's growing bodies? And if I provide girls with family planning services, their reputation will be damaged. And as you can see from the results presented on the slide, we had a sizable number of proportion that agreed with these statements before live prototyping, and at the end, the great majority had improved their attitudes related to provider bias. On the flip side, when we looked at the results from our qualitative interviews, we see opportunities to improve our solution set. So for example, we realized that if we wanted to reward providers based on clinical performance as part of the rewards pillar, it was important to develop a data collection system that was both accurate and trusted. So for example, assessing provider performance based on general questions as whether they are pleased with today's visits, when you ask that to a client, didn't give us the specificity to assess provider bias with accuracy. And in addition, when we tried to collect provider performance using self-completed surveys on tablets installed in health facilities, we ran into issues with clients understanding the questions, but also experienced several cases of bogus client entries, which eroded the confidence of our data collection system. So in any case, the results and lessons learned from live prototyping allowed us to get a better sense that our solution set was working and provided an opportunity to further refine our implementation modality. Next slide, please. So I'm just going to quickly wrap up my case study here and provide a few takeaways from my experience working on an HCD project. So I think we need to carefully consider the data needs across the different phases of your HCD project. I talked about the M&E experience of live prototyping in this particular case study, but there are other phases of the project that require careful consideration. So for example, the ideation phase, when you're ranking the feasibility and the desirability of different intervention modalities. Most of the data needs are qualitative in nature, and you can capture feedback from different stakeholders on promising intervention approaches quickly. On the other end of this spectrum, we had an external partner who led a randomized control trial to evaluate the effectiveness of the final solution set, which mostly relied on quantitative empirical analyses. The second point may be obvious to a lot of folks, but it's very important to have some sort of framework, theory of change, or causal pathway that gives you a better sense of the behavior change mechanisms at play. Once you have a better sense of the sequence of events that lead both to the proximal and distal outcomes across different levels, it's helpful to kind of figure out at the end of the day whether your solution set is working. So in this case, we're trying to improve client outcomes related to provider bias. First, we need to know that the intervention is being implemented as designed. Then we need to see if attitudes of providers are changing. And then finally, look at the results at the client level. The third point looks at the trade-off of an M&E system that focuses on quick results, which usually involves some of the earlier phases of the HCD steps, versus an approach that has more methodological rigor, which usually involves the evaluation of the final solution set. So obviously there are resources implications to consider, both in terms of time and money, but also the generalizability of results, which may or may not be important based on the priorities of the project. And fourth, it's always important to come up with your learning questions that provide a North Star on why you're collecting this data. Also keep you focused on the data that you really need to collect. All too often, partners, key stakeholders are looking to find interesting information and factoids, but do you really need this for the success of your projects? So that just helps you prioritize what you need to collect. And finally, don't discount some of the non-traditional data sources, such as project meeting notes. All too often, we like to develop neat survey questionnaires and interview guides as part of primary data collection, but a lot of useful insights also emerge in project meetings about implementation successes and challenges. So plan and effectively facilitate your project meetings and make sure to take good notes to help you capture and document key insights. I'll pause right here and I'll pass the baton next to Deborah. Deborah, over to you.
Hi, everybody. My name is Deborah Freitas Lopez, and I am a Senior Director and Lead for the GLW Regional Programs. Next slide. I'm going to talk a little bit about Juanita in the beginning of her presentation talked about the various levels that you can work in HCD. And so I wanted to talk a little bit about how URC is actually using it for systemic changes. And in particular, we're aiming to create a culture of quality in Ghana by improving improving health service delivery by bringing innovation and building a trusted, harmonized health system across the public and private sector. And we're doing this across the 17 zone of influence districts in Northern Ghana, and then prioritized 9 districts in Volta, OT, and Western regions. We're working with a variety of key actors, and I think that that's something also that both Bram and Juanita have indicated the need to work with key actors. And with us, that's the Ministry of Health, Ghana Health Services. It also includes the private sector providers, professional boards, the Christian Health Association of Ghana, the quasi-government health institution, and many others. By working alongside these key actors, we aim to support and enhance coordination and collaboration across the various levels of the health system, creating ownership, strengthening leadership and governance, and paving the way for sustained improvements in quality and in health outcomes. Next slide. I'm going a little bit quicker because I know we're running out of time. And so as part of our iterative process, we're actually using it across our entire activity. But I wanted to just give you an overarching piece of how the flow goes, and then give you a specific example of how we're using it for one of our many pieces. And so in particular, the goal is to strengthen governance and leadership of QM and QI, quality management, quality improvement structures and processes at all levels, thereby addressing contributing factors that inhibit the provision of quality service, which then empowers health workers to deliver quality service in public and private sectors at multiple levels. And then as a result of that, also in terms of scale up, working with targeted facilities and communities to drive QM and QI processes, and institutionalizing this idea of collaboration and adaptive learning to become centers of excellence that then can help replicate these best practices across multiple regions and other multiple districts and regions across Ghana. Next slide. And as I mentioned, I wanted to give a really just one example of how we're using it at a micro level in terms of this activity. And so, for example, for the first phase, we did research, and that included interviews, consultative meeting, working on existing data, all doing this jointly with the key actors that I mentioned to you before. And just to gain a deeper understanding of the challenges and the needs towards, in this case, achieving the National Healthcare Quality Strategy. We did a joint review of the existing quality management and quality improvement related documents and courses also. And then we moved on to having workshops with a subset of content experts identified within the pool of key actors for development of draft course materials. And then from there, we had joint workshops with a larger group of these key actors, all towards creating and packaging quality improvement, quality management courses and materials. And this, of course, was an iterative process. It didn't happen overnight. There was a lot of moving forward and coming back and moving forward again, testing some of the materials, looking at what existed, what needed to be updated, what needed to be just removed, and so forth. And now we're actually towards the end of this application phase. And so jointly rolling out the courses. And as I mentioned before, this is done at multiple levels. So we're really doing this iterative process at a regional, then district, then facility level, and so forth. As part of this process, we've created quality management teams across these levels at the private sector as well as at the private. And we're monitoring and adjusting based on these initial rounds, as well as we start scaling up and expanding the work. This, of course, requires continuous evaluation and refinement. And we found creative and non-traditional ways, as Bram has said, to identify like what needs to be refined and what doesn't, and if something is working and not working, and so forth. And always, in our case, this idea of joint work. Our feeling is that this will help with that own scale up for sustained harmonization and this culture shift of quality that we want to create. And so we believe that the only way to get to that is by creating this ownership that we're continuously aiming for. Next slide. So, you know, these are some of the results thus far. Since the project is only ending its first year, we have several more years to go. But we have successfully co-developed quality management, quality improvement courses for the public and private sector that are actually being embraced and used by all. The aim right now is actually to accredit it, and so that it becomes a continuing professional development type of course and gets credit. People can get continuing education credits for it. This continuous participation of key actors, this ownership that we've been striving for is growing. And we've retrained the National Quality Technical Committee on the National Healthcare Quality Strategy and quality management, quality improvement in general. And we've enhanced several of the tools that they're using. And this is all part of that iterative process that I mentioned before. I also mentioned that we've established quality improvement teams across all the regions that we're working in, as well as the districts. And also, just as Bram mentioned, some of the evaluation pieces. So for us, they were pre and post tests. We've also done follow-up training, coaching sessions, and also action plans. And those are all ways that we've gained knowledge about the progress and how successful these courses are going, and if we need to make any tweaks to them. And then we've developed a data-driven QI project. So in quality improvement, the goal is for these improvement teams to identify challenges within their facility or setting, and then create localized solutions. And that in itself is an HCD process that we've taught them to do and that they're using right now. And then my lessons learned, I don't know what happened, but my lessons learned So definitely make time to establish and deepen partnership with key actors. I think that the three of us have said that. It's quite important, and especially now with this idea of sustainability, this really will ingrain it into the work that everyone is doing. For us, the continuous communication with key actors at our level has also ensured sustained implementation. We're taking advantage of all available data sources, including non-traditional data sources. And I mentioned some of those as we were speaking, as has Bram. For us, we've also ensured integration of GESI at the beginning in the intervention, and just really thought about it to be much more than just a target that we had to reach. And this is quite important for leadership and governance, this representation of GESI. And lastly, but not least, regularly engaging the national and subnational leadership to facilitate resolution of challenges at the regional and district levels. This is particularly important when you're trying to implement these micro activities within a timely fashion so that you can push forward with your implementation. I'm sorry I went really fast, but I know we were running out of time. Thank you.
Thank you so much to all the speakers, Deborah, Juanita, Bram. We really appreciate. We have a lot of questions in the chat. I will address some of them. There is one for Deborah. Maybe you can take this one. Are there the example where HCD is not appropriate as a method? Deborah?
Yeah. I think that, I don't think you have to use HCD all the time. I think it's just one tool in a variety of tools in your toolbox, right? And so I think that there are some things that we have identified in our projects that are low-hanging fruits that are not necessarily related to HCD or coming up with an iterative process, right? And so like a really good example in our case is just re-engaging a committee that doesn't require HCD, finding an effective system for everyone to communicate, and it might not necessarily need HCD to do. I think that that's something that actually you should be identifying. In my opinion, this is what we did. We identified it with the key actors that we're working with. What will be needed in terms of, in terms of using this process, and what's not, and what, and if not, then what other process should we use in lieu of that, right? And so sometimes a consultative set of meetings is all that you really need, or that those consultative meetings can be part of your research for an HCD activity. I hope I've answered that question. I don't know if Bram or Juanita wants to add anything else.
Yeah, if I can just add one more thing, and Deborah, I completely agree with what you just shared. Maybe two other points. It's also whenever we're not dealing with a complex problem, whenever we're dealing, for example, with a simple system where we can predict and observe and understand the system and can already have a solution for that problem that we already have, then there is no need about investing a whole bunch of time, a whole bunch of money into understanding a system that is not that complex. The second thing to me, it's also I wouldn't recommend doing or applying a human-centered design wherever we would have to hinder one of the key principles of human-centered design, in which, like, for example, yes, you can do human-centered design, but you can only do research with one single stakeholder, or involve them with just one single research method. So whenever one of the key principles of human-centered design there are much more are hindered, then I would also recommend exploring maybe some other methods too. Bram, anything else that you wanted to share? Or
no, I think that's a great summary. The complex solution. If you are operating in a simplistic linear model, you may not need to do that. But great points, Deborah and Juanita.
A slightly related question for you, Bram, from Lynn. How do you balance applying HCD based methodology on an open mindset with a more structured M&E approach when these can sometimes be at odds?
That's a great question. I appreciate that, because as an applied researcher, there's the rigor methodological approaches that I take dear, but HCD is a different process when it's more open, it's more collaborative, and it's quicker. So that mindset, I think, has to be in the back of our minds, and thinking about the different approaches for feedback loops. So I've kind of moved away from like M&E systems to kind of figure out statistical significance, key themes, to figuring out useful information to move us towards the different phases of that HCD process. Idea generation, prototyping, pilot and evaluation, those are different phases that require different approaches. But I think the most important component is having that mindset of being open, being collaborative. You don't need those p-values every single time when it comes to figuring out feasibility, desirability. So be open and collaborate, and it's a journey and a process for sure. So you also have to be innovative on how you capture that feedback loop and that information that you need.
If anybody has not noticed, Liz McNeil has provided a good resources for additional information on the HCD Exchange at www.hcdexchange.org. Just that was the chat. I don't know if anybody else has noticed. I do have a question for Juanita. So how is HCD different from conventional project intervention planning design, where one usually begins with needs assessment through PLA, PRA, and design intervention through the user, then assess and monitor the gain iteratively with the users?
Okay, I'm not too familiar with those other methods, so maybe I can also rely a bit on Deborah and Bram for this one. Guys, do you have any suggestions, recommendations to answer that question? SOS.
Yeah, can you repeat it one more time, Sibel, and then I'll try to answer it.
Oh, absolutely.
Sure.
How is HCD different from conventional project intervention planning design, where one usually begins with needs assessment through PLA, PRA, and design the intervention through the users, then assess / monitor the gains iteratively?
Yeah, so I used to also ask that question when I first started doing HCD and considering it. And I think the slight thing is that one of the key things is that it's actually it's often happening simultaneously. So as you're implementing like a new iteration, you'll make tweaks on the spot, and you're making these. You're not waiting until you've had a moment to evaluate the data and to assess it and sit down with a group of people to review it. Then you go back out. You may do that, but it's usually like happening more fast pace. It's still participatory. I mean, I think we've all indicated that you need to have these key people at the table with you doing this work. You can't like not do that. So it's definitely participatory, but it's just it's very nuanced. It's a lot faster, and it's more agile in the way that you work, because you may find, for example, that you're working on an intervention and it's just this tiny little piece of it that's not working. And so you focus on that piece versus like the greater part of the intervention. And when you're doing this these iterative rounds, you can actually zoom into that little tiny piece. I hope I've made it clear. I don't know if Juanita or Bram, but a needs assessment is slower. Focus group discussions are slower. You have to collect all this data and do a trend, and you may not be doing that. And then as HCD, actually, you can have it be happening simultaneously across like multiple areas, right? So they don't necessarily, you don't go from one site to another. You could, or you could do it all at the same time. So I don't know if Juanita or Bram, you want to add anything else.
No, that was great, Deborah. I think the quick feedback loop is a nice presentation.
Yeah.
And the fact that things are happening at multiple levels simultaneously, because from the M&E trained M&E professional, I want my needs assessment happens here, this happens that,
Yeah.
but things are happening simultaneously,
Yeah.
and you're looking for quick feedback loops, and therefore taking advantage of some of these non-traditional data sources that often M&E professionals are more accustomed to.
Yeah. And I just want to add that, you know, there's this perception that HCD is more expensive than like the traditional linear process that we're all accustomed to follow. But on some level, it's actually more cost effective because you're actually making adjustments as you go. And so you're not waiting until you have all this data, all this information in order to make those adjustments. You're making them as you go.
Thank you all. I think we're running out of time for the questions. We will we'll share the speaker's email if you have more questions to reach out. Jordi, you want to take it?
Yes, just to summarize what we heard in the past an hour or so. Thank you, Bram, Anita, Deb. It is really excellent to hear how HCD applies in our world, in our M&E world, and excellent questions are coming still in the chat, and hopefully the conversation continues. And you know, what stood out was how such new innovative approaches are becoming very important in our field, in our M&E, because we are working in a very complex environment, and we are dealing with multiple systems. So HCD and the likes of it are, you know, the new directions that we will be using more and more in our field in M&E. And thank you for highlighting, Anita, Bram, and Dave, how important it is to always go back to the drawing board and look at our theory of change and find ways to integrate HCD and be flexible, as Bram was saying. We need the mindset because we are used to doing certain things certain way as traditional M&E professionals, most of us. So, you know, that flexibility and openness to do things iteratively and adapt as we go is very important. So hopefully this is not the end. This is the beginning of the conversation, and we hope this M&E working group will be a very good platform to continue conversations and sharing experiences and lessons. With that, we conclude our sessions for today. Thank you. Thank you very much. Bye-bye.